This is an overview of an article entitled Effects of Genetic Variants Associated with Familial Hypercholesterolemia on LDL cholesterol levels and cardiovascular outcomes in the Million Veteran Program, published in the December 2018 issue of Circulation, Genomic and Precision Medicine. Familial hypercholesterolemia, or FH, is a common genetic disorder affecting approximately 1 in 250 adults. The condition causes lifelong elevated levels of low-density lipoprotein cholesterol, or LDL-C, which substantially increases the risk for developing atherosclerotic cardiovascular disease, including early-onset disease. A recent study suggests that carriers of FH variants have an elevated risk for incident coronary heart disease, or CHD, that's independent of a single measure of LDL-C. Many causal mutations for FH have been reported, and more than 1,000 variants have been documented in the LDL receptor, or LDLR, gene alone. The phenotypic effects of most FH variants have been assessed either in pedigrees without proper population controls or in population samples without sufficient sample size to assess phenotypic effects of individual variants. The majority of published genetic studies of FH were conducted in samples of European ancestry. While the prevalence of FH is higher in African Americans, the knowledge of FH variants in minority populations is very limited. To determine LDL-raising effects and to better understand the distribution of rare FH variants, the authors of the paper under discussion examined pathogenic and likely pathogenic FH variants and their associations with LDL-C levels and clinical outcomes among more than 300,000 multi-ethnic veterans in the Million Veteran Program, or MVP. The authors identified at least 30 carriers for 16 FH gene variants that were classified as pathogenic or likely pathogenic. These variants were individually assessed for association with the maximum LDL-C level measured in each MVP participant over an interval of 15 years. A total of 8 of these 16 variants, including 5 in LDLR, 2 in ApoB, and 1 in PCSK9, were significantly associated with elevated LDL-C levels compared to non-carriers after correction for multiple testing. These effects of individual FH variants were highly heterogeneous, as shown in this table. The variants with the largest effect sizes were relatively less common. This figure shows that the distribution of maximal LDL-C levels among carriers of each FH variant was also highly variable, with some carriers having levels lower than 100 mg per deciliter. The red horizontal line at 190 mg per deciliter indicates the threshold for severe hypercholesterolemia. The blue horizontal line at 140 mg per deciliter represents the mean maximum LDL-C level of the multi-ethnic MVP participants. This table shows the phenotypic effects and distribution of individual FH variants among 214,455 MVP participants of European ancestry and 57,850 MVP participants of African ancestry. There were highly differing allele frequencies between the two ethnic groups, although the effect sizes of the variants were fairly concordant. The authors further examined the combined effect of pathogenic FH variants that substantially increased LDL-C levels, that is, a mean increase greater than 20 mg per deciliter, within each of the 3 FH genes. The FH variants in ApoB conferred the highest mean effect on LDL-C levels. Finally, the authors determined the collective impact of the deleterious FH variants on a wide range of clinical outcomes through a Phenome-wide association study, or PheWAS, by leveraging data from 61.7 million clinical encounters across 3 million patient years of health data. Among more than 200,000 participants with European ancestry, the authors examined 1,171 diagnoses within 17 categories of disease based on ICD-9 codes. Compared to non-carriers, carriers of FH variants had a statistically significantly higher prevalence of clinical diagnoses related to hypercholesterolemia, and CHD-related diagnoses, including ischemic heart disease, coronary atherosclerosis, and angina pectoris, as shown in this figure. Adjusted for age, sex, and the top 10 principal components for population structure, FH variants were collectively associated with a greater prevalence of CHD, with an odds ratio of 1.68, but not peripheral arterial disease. After further adjustment for maximum LDL-C level, the odds ratio for CHD was 1.59. In conclusion, 8 out of 16 putatively pathogenic FH variants with at least 30 observed carriers were significantly associated with elevated maximum LDL-C levels. The phenotypic effects of these variants were similar for European and African Americans despite substantial differences in carrier frequencies. And FH variant carriers had a higher prevalence of clinical diagnoses related to hypercholesterolemia and CHD in a Phenome-wide scan.